Good morning. It has been a long, tough pandemic for all of us. We have been worried about getting the vaccine. We've been worried about people not getting the vaccine. We've been worried about wearing masks. We've been worried about people not wearing masks. There are people who are worried about work. They're worried about not being at work. They're worried about juggling work and school, about taking care of parents. They're getting behind in school. They miss their friends, their routines. And all of that is causing a gigantic spike in the number of people who are reporting symptoms of depression and anxiety and other diagnosable mental health conditions. Good morning. I'm Leslie Boney with the Institute for Emerging Issues at NC State University, and this is First and Future Live, our bi-weekly program where we talk about the people and policies that are affecting North Carolina right now. We try to find folks that are working on solutions to the biggest challenges our state is facing and ask them what they're doing and how they're doing it. And then we turn to you and ask you for your ideas. So if you're joining us today, whether by LinkedIn Live or Facebook Live or YouTube, we ask that you submit your questions to us and we'll get as many of them as possible answered. We really appreciate your joining us and sharing, particularly on this topic, because it's something that everybody has some experience with. Every one of us has been struggling in one way or another with the challenges of mental health over the past 20 months. This past June, a coalition of healthcare agencies sent a letter to the governor, the president pro tem of the Senate, and the Speaker of the House, noting that North Carolina ranks near the bottom in access to mental health services and declared that we were in a, quote, state of emergency. More recently, universities across the state have taken note as high-profile suicides or suicide attempts at UNC Chapel Hill and other schools have called attention to a growing mental health crisis among young people. Mental health is an issue that the Institute for Emerging Issues has been looking at and paying attention to for a long time. We had a forum devoted to the subject last fall. We had recommendations that came out of our Emerging Issues Forum this past February, and a number of podcasts, including Kylie Foley's most recent one focusing on clergy mental health. Today, we return with some updates and some guests who have special insights. We want you to please submit your questions, regardless of the platform that you're on, about what you're seeing and how you're adjusting. And then we want to talk about what we can do about it. As guests, we'll be talking with a recently graduated student who will speak boldly about his experience during the pandemic and the head of behavioral health for our state's biggest insurer. Brittany Wake from North Carolina State University, who was supposed to be with us, was called away for an emergency. She'll not be able to join us. But let me just start first with a few statistics. We know that mental health challenges are up dramatically for all groups, and for some groups even more than others. As I mentioned earlier, more than half of 18 to 24-year-olds and people with job loss are both experiencing symptoms of anxiety and depression at rates over 50%. Others with high rates of anxiety or depression are women who have children under 18 in the home, Blacks, Hispanics, and all those groups are trending at a slightly higher rate than all adults. And the all adults number is pretty surprising itself. When we started the pandemic in just before 2019, about 11% of us were experiencing symptoms of depression and anxiety. That has almost quadrupled since then. So huge increases. At the same time, mental health treatment rates have gone up only slightly. They're still relatively flat. So the increase in the people seeking mental health treatment has not increased nearly as quickly as those who are reporting symptoms. We want to try to unpack some of those trends over the next hour, and we wanted to start with one of the folks who's been looking most carefully at what's going on at a state level. Dr. Nora Dennis is the head of behavioral health at Blue Cross Blue Shield of North Carolina. Dr. Dennis, welcome.
Thank you so much. I'm so glad to be here this morning.
You heard me talk just a second ago about some of the national data with regard to mental health. And I'm wondering what you've been seeing over the past 20 months as you've heard people across the state, both talking about what's going on in their lives, but also looking at the numbers, the claims coming into Blue Cross Blue Shield of North Carolina. Can you say anything about trends when it comes to race or gender or geography? Are you noticing anything there?
So it's difficult for us to look at race in particular because racial data isn't universally reported for commercial insurance plans. So we do have race data for Medicare, but we don't have it for commercial plans. We can, something that is certainly a point of great. It looks like, am I sort of popping in and out, Leslie? I apologize if that's the case.
Yeah, we missed, you were making a point about the difficulty of disaggregating race when it came to commercial plans, but maybe you could just speak to Medicaid or Medicare claims that you're seeing. All right. Still having a little bit of trouble with your signal. Go ahead.
Let's try something here. We're seeing increases across the board in utilization of behavioral health services, which is certainly a point of concern and of a great attention for me. And something that I put a lot of energy towards is really thinking about access and how we can improve access. And as we think about it from the perspective of disparities, we know that our Black and Latinx members do have a more difficult time accessing care, and that is for a number of different reasons. And we're really trying to address that. I would say fairly aggressively. In part of the solution, of course, is telehealth services, but then also part of the solution is really thinking about trying to make sure that we have a provider population that reflects our member population. And right now there's discordance there, which is challenging, because I think that when folks go and are seeking behavioral health services, there's a lot of vulnerability there. And so sometimes I think it's more comfortable if they are seeing a provider who they feel can really understand their lived experience.
Yeah, just to be maybe a little bit more direct about that, you're saying when somebody comes in seeking behavioral health insurance, behavioral health services, they would like to see somebody who looks like them.
Often. I mean, I think that option should be available to them.
Yep. You talked about telehealth services, and we mentioned on our last show that between 2019 and 2020, Blue Cross Blue Shield was reporting, I think, a 7,500% increase in people availing themselves of telehealth services, but help via the internet for behavioral health seems to be a particularly promising use. Have you seen similar increases in the number of people who are able to avail themselves of telehealth for behavioral health issues?
So when we looked at 2020, we looked at just our telehealth services overall. 54% of those services were for behavioral health. So certainly proportionately, behavioral health really kind of stole the show in terms of telehealth access during the pandemic. And I think it sort of intuitively does lend itself very well to telehealth as a platform for allowing folks access to providers.
One of the questions that I guess it's hard to disaggregate, but I wonder if you've been able to make any progress on, is that we've been seeing more high profile people who are coming forward and reporting behavioral health problems. So during the Olympics, Naomi Osaka withdrew, Simone Biles withdrew, and both cited mental health challenges that they were having. And I'm wondering if there's any way of telling whether the increase in numbers that you're seeing has to do with people feeling like they have permission to report challenges, or is it really that this pandemic is just really hard on folks?
I think it's really both. So we have a situation where we do have more high profile individuals coming forward. And I think that really does break down stigma in ways that are very, very positive. And at the same time, what we see is that the universality of the experience of behavioral health distress is just much greater now. So there are simply more people who are experiencing behavioral health challenges. And I think that whenever something, in the context of the stress of the pandemic, which has been just tremendous, what it has made these problems more common. And I think then is sort of allowing a space for discussion of the experience and again, breaking down that stigma.
We know that North Carolina has, as a number of states do, but North Carolina in particular has a shortage of mental health professionals. And you talked about the importance of increasing the diversity of those who are providing mental health services. But there's also a geographical challenge. There have always been more in urban areas than there are in rural areas. And you talked about the increase in telehealth services. How useful is that as we try to overcome those geographic disparities in the number of professionals that are available?
I think that you're sort of touching on a really important point, which is that there is a definitive limitation in the ability of broadband or telehealth to solve this problem because of broadband limitations in the state of North Carolina. So, of course, we are a predominantly rural state, and there is something known as the last mile phenomenon, which is this phenomenon of broadband where you sort of get to a certain point and then the subsequent cost of expansion to those really rural areas is quite tremendous. And I can give the example, like last week I was on vacation with my family and we were in Cashiers, North Carolina, and the place we were staying said that they had Wi-Fi, but it was so slow that if one person was like looking at anything online, then nobody else could do anything, or the whole thing would just like grind to a halt. So really the speed of the internet in that location was not anything close to sufficient for telehealth services. And there are many parts of our state that are like that. And there was also not cell phone coverage. It's not like I could, switch over to my cell phone. It was just like you couldn't access the services in that way. And so when I think about access to behavioral health services, I think we do need to maximize what we can achieve with telehealth, but also to understand that that's not going to get us all the way to where we need to go.
Yeah, it's interesting. There are at least two challenges that we've tried to highlight as an organization. One is the absolute access. Do you have the ability to get any internet at all? And related to that is the speed that you were just talking about. And then there's the challenge of adoption. And in many rural areas, as many as 50% of people who have access aren't bringing internet into their home. And so those two things sort of conspire to create health challenges and obviously learning challenges and work challenges as well. So I think you're really hitting on a big, important issue. Is if someone does have access, though, I think one of the promises of telehealth is that perhaps that provider does not need to be in their backyard. They could be anywhere in the state, and in some cases, depending on the laws of a particular state, in another state as well, to provide treatment.
Yeah, and I think that is the really positive aspect of telehealth, is that it does, once folks have access, it does kind of open up a new world of possibilities in terms of finding a provider. And I particularly also think about those folks who might need, let's say, a certain type of specialized psychotherapy that's not available in their community, but might be available more broadly if they're able to sort of have a wider span of options of folks who might be able to provide services. I did also want to get back, Leslie, to something that you mentioned, and just to kind of touch on it a little bit more, which is that if we don't address the challenge of telehealth and making sure that we're really thinking about all North Carolinians when we think about access to behavioral health services, we can find ourselves in the position of actually widening health disparities because we have sort of this whole world of access and possibilities for folks who have access to the internet, who have broadband, which again is not free, so we all know we get that monthly bill, and that puts it out of reach for many low-income North Carolinians. And so you have this one sort of group of people who has anything at their fingertips, and then you have another subset of the population that continues to have nothing, and might even have like less focus if we're not specifically thinking, okay, well, what are we doing for folks who don't have internet access? How are we making sure that their behavioral health needs are being met?
One number we saw last time is that more than 1 million North Carolinians to pay $60 a month for a broadband connection would be 2% of their income. So a huge percent of a low-income person's income could be devoted toward broadband if we don't come up with some sort of affordability solution. And that then constrains their health care, and it creates that disparity you're talking about. This is, we've been talking about statewide data, and statewide data is made up of a series of individual stories. And I wanted to bring in our other guest. Some of you remember Chris Suggs from a previous interview that we did on First and Future. At the time, he was a freshman at UNC Chapel Hill, I think, and now he is a graduate of UNC Chapel Hill. And he was on our First and Future program back in 2018, talking about his work founding Kinston Teens. He's now running for city council in Kinston. Chris, welcome back.
Thank you for having me.
You were just finishing your junior year when George Floyd was murdered. You were a leader of the Black student movement at UNC Chapel Hill. At some point along the way, you lost a job, and you were also trying to serve as senior class president. And you've been really open about some of the challenges that you were facing and have gone through. And I'm wondering how you could describe what your pandemic experience has been like while you're in school and what help you were able to get.
Right. 2020 was a difficult year for so many of us. At the same time, I think the year and the pandemic exacerbated some of the challenges and issues that, many of us were dealing with already individually and then collectively as a society. And, finishing out my junior year in the pandemic, it was like we were in the middle of spring break, actually, when things really hit the fan. So, being at the beach with friends and stuff, and then our phones start blowing up about, campus closing and, being told to shelter in place. And, things just went extremely downhill from that point. And, trying to navigate life, me having health issues of my own, so being immunocompromised, living or at home in Kinston with my parents, my sister, my grandmother all in the house was also a challenge because, I want to be around my loved ones, but at the same time, I'm, in a densely populated place or campus in Chapel Hill. And now I have to stay away from the folks who I've known and been around my whole life just out of a want and desire to keep them safe and keep myself safe. So, the year was extremely challenging. It got to a point that I lost my job, my source of income, right at the end of my junior year. So then heading into my senior year with all the difficulties of classes, trying to graduate, trying to find, what your next step in life is going to be in terms of employment. And yeah, the year was extremely difficult, and not just in terms of the pandemic, but also the social unrest that happened all across our country, even in Chapel Hill and Durham and places in North Carolina where we organized protests and took to the street because of what was happening across the United States. I'm so grateful that I've been able to navigate out of many of the challenges that I experienced in 2020, but it wasn't an easy task. As a student at Chapel Hill, at the University of North Carolina at Chapel Hill, I did immediately, seek help through the university services in terms of campus health and trying to get, mental health help, because I knew that this was a crisis that I was going through and something that I needed professional help to kind of navigate and ensure that I was able to continue being a great student and a leader. And unfortunately, I ended up my best route or my best option for me at the time was to actually withdraw from the university during the fall semester of my senior year. So that was a lofty and difficult decision to make, but I knew I had to do what was best for myself, best for my future, as well as just understanding the fact that there were significant limitations of what we had access to as a student in terms of mental health services at Carolina. So It was both disappointing, but also kind of gratifying in a sense that I made such a difficult decision, and it has put me on a positive trajectory since then. But it really highlighted for me some of the inefficiencies, some of the inequities that we as students face at our institutions of higher learning.
How did you make that decision? Because that's really hard. I mean, you're on this, you've been kind of a hard charger your entire life, and you're charging ahead and you're juggling 5 different balls. And at some point you had to look yourself in the mirror and say, I need to just take this time off. How hard was that for you?
Right. For me, I think at first I did not want to withdraw from the university. I wanted to be involved in my classes. I still wanted to, serve in my leadership positions on campus and, be able to see my friends. But at the same time, I think what really pushed me to that decision was realizing that the direction we were going in at the time as a university, as a society, wasn't sustainable for my mental health or for the mental health of so many others who, I was in communication with. UNC was one of the universities in our state and in the country who decided to really go back in full force back in August of 2020, returning students to campus for in-person classes and on-campus housing. And I think for me, that is really what kind of pushed me to the point of, I can't be a part of this. I can't, push through and act like everything is okay when nothing at all we're going through as a society right now is okay. Nothing I'm going through personally is okay. So I think what it was recognizing that it's okay not to be okay. And I don't want to really have a hand in, trying to fake it till I make it. And at the time, I sought out professional services on campus. I ended up, enlisting a counselor and therapist outside of campus through my own, private insurance and private medical care. And that was a huge help in being able to have access to some mental health services to help me navigate what I was going through. And also just having someone to talk through about the issues going on in my personal life and across the country. So that did put me in a great position to be able to return to campus back in the spring of 2021 and graduate and, graduate successfully as senior class president and stuff. But it really, shows some glaring issues in terms of just what we have access to on campus, what students have access to, and even thinking about if, a student other than myself, someone who wasn't as connected with other campus departments and campus facilities or mental health services. Fortunately, I knew about the resources across campus. Not every student is aware of what we do have access to. And then when they do reach out at times, those resources can sometimes be understaffed or unable to fully support us in what we're going through.
I think one of the hard things is that a lot of people don't talk about what's going on with them. And so they sort of think that their case is unique. And I just wanted to show a slide that gives some numbers to the number of people who are thinking in the same way and looking at some of the same issues that you are. Out of 18 to 24-year-olds, the percentage reporting increased stress and anxiety, 71%. Of those who talk about that stress and anxiety, they talk about their worries about health, difficulty concentrating, disruptions to sleep, decreased social interactions, concerns about academics. Which of those resonates with you and your friends and the folks you've talked to?
Yeah. Honestly, each of those concerns, each and every one, our conversations with, my conversations with my friend group have been all across this board, even, other things too. But, health has been a very primary concern, especially for those of us who, may have some health issues pre-existing prior to COVID-19 or, worrying about the health of our family members. I don't think I've ever experienced the amount of loss that I have over the last year and a half ever in my 21 years of living. And, losing my grandmother in the midst of the pandemic back in March of this year. And then, several of my friends also lost grandparents too. So we're all going through personal challenges, losing family members because of COVID or because of other issues that were exacerbated by COVID-19. And then trying to support each other and navigate all of that. It has taken an extreme toll on folks. And what should be some of our best years, graduating, starting careers, starting families, things like that. And we're just trying to survive. I think that, each of the concerns that you showed that from that data point really highlight the conversations I've had with, other folks in my age group.
Let me ask you, I'm going to bring Dr. Dennis back, and let me ask you both about a disparity question. And Dr. Dennis talked about this a little bit earlier. We saw earlier that Blacks and Hispanics are experiencing higher rates of symptoms of anxiety and depression. But when it comes to treatment, there's a history of lower usage of mental health services. Whites access services at about twice the rates of Blacks and Hispanics, and almost 3 times the rate of Asians. Why do you think that is? What is it that is not working about this system? Again, these are numbers from before the pandemic, but and I don't have updated numbers on access during the pandemic. But assuming those numbers are continuing, any ideas about why that usage rate would be lower? Is it an insurance challenge, or is it a cultural challenge, or what's going on?
So I will speak first, and then would be really interested to hear Chris's perspective as well. So my perspective on this is that it's in part certainly due to structural racism. It's due to the fact that service availability, as we sort of touched on earlier, is certainly quite heterogeneous across this state or any state. It has to do with the fact that, the provider community doesn't necessarily look like the patient community. And there's also just a long history of, I would say, insufficient services that have really left folks with trust challenges as well. And so I can give the example of in psychiatry, we have a history of misdiagnosing Black people who have major depressive disorder with psychotic features, meaning like very severe depression to the point where you're hearing voices, seeing things, quite a difficult condition, but treatable, and folks being misdiagnosed with schizophrenia. And this is well known, very consistently demonstrated. Schizophrenia is a lifelong, chronic, essentially neurodegenerative behavioral health disorder. And if you are diagnosed with that, you're going to get the wrong medicines. You're going to be treated inappropriately, and it's really one of these things where folks do not feel like when they go to seek help that it actually makes them better. Then they're not going to do it. And I'll just end with an anecdote about a patient who I had back when I used to work at the Durham VA Medical Center. And he was a lovely and brilliant man, and he had bipolar disorder, and at one point went to the emergency room in a state of distress, and he was handcuffed, and he was treated in a way that was like incredibly traumatic for him. He's a really intelligent, sensitive person. I think that would be traumatic for anybody. And so then that kind of left him with an aversion to seeking care if he was doing poorly, because he was afraid that he was going to basically be like physically attacked, and so there was like a threat perception difficulty that on the part of that those providers, and that led to him having a really difficult experience. And so I think we get into this cycle where people, if we don't have availability of outpatient services for BIPOC communities, and then those folks end up being very sick when they finally seek care and end up in the emergency room, which is an incredibly aversive experience. That then is not gonna feed into folks having trust in the behavioral health system and wanting to seek care early. It's going to lead to aversion.
Thank you. So definitely some misdiagnosis and historic distrust of that system. You talked earlier about the diversity of treatment professionals making a difference. Chris, any observations about this?
Yeah. For me, it's the fact that health disparities are still very real and very glaring. I think about the fact that, I grew up in East Kinston, which is the #1 most economically distressed census tract in our entire state. And to then spend 4 years in Chapel Hill, one of the richest communities in our state, and having access to any resource, any healthcare resource. Every time I turned my head, there was a new doctor's office popping up in Chapel Hill. And so many of us across the state, especially in small rural communities like Kinston, still don't have access to healthcare, access to mental health services either. Even for much of my healthcare now, I've been back home in Kinston after graduating from Chapel Hill. I still go back to Chapel Hill for routine medical visits because of the adequate care, the high level of care that I can receive in Chapel Hill compared to my rural community in Kinston. So for so many of us living in poverty, living in rural communities like Eastern North Carolina, that access to care is still not available. And it's, a result of just, both poverty and economic issues, but also the very real structural racism, medical racism that Dr. Dennis, referred to. So that's still the case for many of our communities, something I, can personally attest to. The fact that I'm, spending money on gas, money on, time on travel, going back to get adequate access to healthcare. And so many folks in my community still don't have the same resources and opportunities that, I've personally been afforded to be able to have that access. So we still have a long way to go in eliminating those barriers, eliminating those structural inequities, so that, no matter, your race, no matter your zip code, you still have access to healthcare and mental health services.
Thank you both. We're starting to get some comments, and we welcome your comments. Please lob them in through the chat or comments function, depending on which platform you're using, whether you're on LinkedIn Live or Facebook Live or YouTube. Please just submit those comments and questions, and we'll get to as many of them as we can. Dr. Dennis, one of them has to do with how the uninsured get mental health services. And I know you're working for an insurance company, but you also know about how the uninsured can access mental health services. How does that work?
So in the state of North Carolina, there is funding for uninsured individuals to receive care, and that funding is distributed through the MCO system. So we have the state is sort of divided up into different areas, and those different areas are under the purview of different managed care organizations that then contract with providers. Usually these are nonprofits. I used to work for a nonprofit called Monarch, and Monarch was a behavioral health services provider that then would see folks without insurance and would then be able to sort of file claims back to the MCO for the care for those individuals. I would say that as a whole, that system is not sufficiently funded to meet the needs of the population, just because there are a lot of people who need services, and that we know that for behavioral health, as for any other medical condition, that the amount of time between when someone schedules their appointment and when they are seen essentially determines the likelihood of them actually making it to the appointment. And this is significantly even, more the case when people are struggling with transportation challenges, or perhaps when they have a job where they actually can't get sick leave or easily get time off. There are just all of you kind of like can see all of these different barriers that stand between the individual and the care that they need. And then the last piece I think that's really hard is that those jobs, those roles, it's a hard job to provide mental health services for folks who are, so much of their suffering is derived from factors that you as a psychiatrist or a therapist really cannot control. And I think at times it feels reductionist. Like if somebody comes into me and they've had this history of trauma and they are stuck in poverty and they have all of the stress in their life, for me to say like, here, have some Zoloft is I think that there would be a degree of sort of intellectual dishonesty about that, because I know and they know that a pill is not going to address the full scale of what they are dealing with. And one of the things that I repeatedly found really challenging within that system was that it was the people who were in many ways the most vulnerable and the most complicated. And then you often had the providers who were at the very beginning of their career, were the least we're the least experienced providers, just because of the way that these sort of systems work, right? Like you're right out of school to become a therapist or become a social worker, and then you can't get a job anywhere that you want. But often, because of the intensity and of the stress of working within the public mental health sector, it's easier. And so it's just that like discordance then almost like will lead to sort of a cycle of burnout for providers within that system. And so we have a scenario where those services are available and they're funded by the state, and I'm grateful that is the case. And I think there's very broad recognition that system is in no way fully meeting the needs of all the people who are depending on it.
There's a question about rural urban, and it touches on some of the issues that you just brought up, Dr. Dennis. The experience question. In some cases, the less experienced providers are in rural areas. They get experience and then they move to urban areas. In other cases, they don't move there earlier. There's a comment from Greg on LinkedIn Live, just talking about mental health in some rural areas. And in some families, doesn't happen nearly enough. So there's a conversation issue, but there's also a provider supply issue. And you talked earlier about telehealth and the role that can play. Chris, I wonder if you could, and you talked a few minutes ago about needing to get some of your services in the more urban area of Chapel Hill rather than in Kinston. Is there anything we can do to convince more providers to locate themselves in rural areas, or is telehealth the solution?
Yeah, telehealth is definitely not the one solution. It's part of, what we can do to fix and part of the solution. But even here in rural Kinston, Illinois County, we still don't have adequate access to broadband. So, telehealth will be a great option for some folks, but not all of us. I think, in terms of the mental health conversation and the lack of adequate access to healthcare in general for rural communities, it speaks to a broader issue and part of the broader, in economic inequities, the lack of, community and economic development in our communities, so that when folks return home from college or return from completing medical school, that they do have adequate places to live and survive and have access to the other resources that may be attractive to them in a college community like Chapel Hill or in Durham or Raleigh or somewhere. So, even for myself, a young college graduate, just moved back home, it was very difficult for me to find employment back home in Kinston, find an adequate place to live in Kinston too. So, if we want to encourage providers to move to these rural communities and be able to provide services there, in terms of a state, in terms of our municipalities, we also have to ensure that we're doing whatever we can to invest in these communities, ensuring that they have the infrastructure, the housing inventory, as well as the other services and resources that make these communities thriving and quality places to live in. So really the mental health issue in general, I think, though, speaks to, and Dr. Dennis mentioned something about, it would be honestly kind of intellectually dishonest to just prescribe a pill to someone who's going through so many other structural and systemic problems in their life and dealing with so many other things. And that's been my experience as a student too. Over the last few years, there have been a number of circumstances that have converged at UNC Chapel Hill that have, just made the academic experience very stressful. And one of the immediate calls from student organizers, from community members, is for the university to give us a day off or give us a wellness day. And oftentimes that call is met with deaf ears, but at the same time, there's not enough wellness days, there's not enough days off from class that could really help us get through and navigate the issues that students are experiencing, because these things are much broader than what we're experiencing on campus at our university, when we're also trying to survive a pandemic or deal with family issues or economic struggles that are beyond any of our immediate control. So it really speaks to the need for our legislators, our community leaders, our government officials to address many other quality of life issues to really exacerbate and eliminate some of the things that are causing mental health stress in our communities.
Good points. I want to just bring up a couple of other things that that you were just addressing, Chris. First is an observation by the UNC Systems Board of Governors that there really is there are some challenges in terms of availability of services, even on UNC system campuses. So they came out with a report in May of this past year that called for more sustainable student mental health care. And among the various things they wanted to look at was more funding, whether through insurance recovery or philanthropy or more student fees, perhaps, increased staffing, better training, better data, increased crisis intervention, alternative service delivery. And I'm wondering, as you two look at those, are there any that stand out as being particularly important based on your experience? Or Dr. Dinesh, you as a counselor, Chris, you as a student and somebody who knows a lot of other students.
So I think that for me, the things that really stand out, first of all, funding is always I think a really critical point. My understanding is that if we were to appropriately fund behavioral health services on campuses, there's every possibility that that would actually be net neutral or even potentially have a positive return for the system, because the number one reason that they lose students, that students drop out, is because of behavioral health problems and concerns. So that to me is such a tragedy, because we are losing the brightest minds in our state to behavioral health problems. This is not only a health problem, it's an academic problem. And I think that the need for data, the need to take sort of a systemic approach is really critical as well. So I think we have to think about this as a public health crisis and then approach it of solutioning.
Thank you. Chris, what stands out to you from this?
Yeah, I'll absolutely second the need for more funding. And, in reading the Board of Governors report from May, one of the things that was highlighted by this report was that some of our smaller institutions here in the university system, whether they're our HBCUs or some of the smaller colleges, many of their mental health services or student health services were actually grant funded or funded by philanthropy. And I think that's one thing that I would say as a student, as a North Carolina resident, that we would need to move away from. This isn't something that, mental health and healthcare shouldn't be something that is, time limited to a grant application or a grant funding period. But this needs to be something that is systemically ingrained in our state's budget and our university budget, so students know that these resources are here to stay. These resources are part of our university apparatus, but not time limited or some special program that might go away in a few months. So that would be one thing that I would, strongly advocate that our Board of Governors, our university leaders at the university and the system level, really look into ensuring that this funding for university programs in terms of healthcare, mental health services, behavioral health services is ingrained into our system, and it's something that students know and can trust that we can always count on and have access to. The other thing is definitely increased staffing and training. I completely agree with that recommendation too. In terms of what I've experienced over the years at Carolina and hearing from my peers when I served as senior class president in Carolina, was that, students would reach out to, campus health services or student health services on campus, and the staff would say, this is, definitely an issue that you need to seek support for, seek help for, but it's beyond what I can provide you any assistance with. You might should seek care off campus somewhere or make a referral to somewhere off campus. And, that is extremely difficult, a very difficult position for students to be in. And, we're at, our university system's flagship university, the southern part of heaven, as we call it in Chapel Hill. And we can't even get adequate care on our beautiful campus with all the resources that UNC has. They're referring us elsewhere. So that, also presents another barrier in terms of access, transportation, finances, but also a disappointment for students who, finally, felt the bravery, the courage to go and seek help from their university, and just to be told that we can't help you, I'm sorry. So, that increased staffing, having staff with more capacity, more training, more knowledge and resources to support students is something else that I found in my own experience, but also in talking with my peers at Carolina.
Someone notes on Facebook Live that some campuses limit the number of behavioral health visits you can have in a particular semester, and I don't have confirmation of that one way or another, but I can certainly see that if you have inadequate funding, that you're going to have to limit the amount of service that any one person can access. Dr. Dennis, is that true in your experience?
So I don't have a ton of personal experience with campus health. It certainly wouldn't be surprising because it's a sort of a degree of like rationing the resource. So, if they have limited resources and they want to make sure everybody gets some of them, then I think that that would be probably an understandable approach, although not what the moment calls for at this time.
Let's take this up one level from campus and 18 to 24-year-olds to the state as a whole. And this is these are some excerpts from a letter that came out in June from the North Carolina Healthcare Association, the North Carolina Chamber, NAMI, the State Mental Health Organization, the North Carolina Medical Society, and several other groups. And they made several observations that are statistically true. One noting North Carolina ranks way near the bottom of states in terms of access to mental health services in general, and even lower in youth access to mental health services. They noted skyrocketing demand, a piecemeal approach, inability to meet escalating needs, and declared that we were in what they called a state of emergency. And let me just show one other set of solutions and then ask you guys to comment on either of those. These are just some of the different ideas that people are beginning to pilot in North Carolina. There are bills before the General Assembly, and there are proposals nationally that people are raising up. One has to do with police and mental health, noting that a lot of the police shootings and some of the challenges that are there is because police have misperceived mental health challenges and confused them with criminal challenges. There's a bill pending on that. A bill that an issue that we've called attention to in our last February forum was the idea of starting more peer-run mental health resource centers. There's a bill pending on that. Dr. Dennis talked earlier about increasing the diversity of psychiatrists. Currently, only about 10% are people of color. Introducing mental health early on into public school curricula so that you, on some level, early on destigmatize mental health challenges. And then telehealth reimbursement parity is another issue that people have brought up that might be effective. And I'm wondering if you guys could react to either of those, either the letter that outlines some of the challenges North Carolina has, or some of these solutions that people are lifting up.
So I think that the letter was very timely. Certainly, it's been the case in my professional experience that there's a lack of awareness of how critical the situation is until one has either one's own experience or a family member or loved one who needs care. And then you find that you actually can't find care for them. And that's, I think, a sort of a terrifying experience. And it does fail patients. And there is tremendous fragmentation in the mental health system, more so, I think, than even what we see in the context of the healthcare system as a whole. And the result of that is that people get lost in the shuffle because it's hard to figure out how to find the care that you need. I think that the ideal state and sort of part of what we are looking at in the context of at least Medicaid reform is that there's really a lot more emphasis on care coordination and on sort of keeping track of people and helping to make sure that they're able to access the services that they need. But I think that there's another piece to this as well, which is really thinking about the interoperability of our systems and the exchange of information, and the sense of people having a medical home and having sort of someone who notices how they're doing and where they are and what they need. And I think at Blue Cross, that's certainly where we want to move towards, is to really be pushing for whole person care that is meaningful in the primary care setting, and then really clear referral networks for behavioral health as well. And there are really big challenges to that. And I think that sort of not on this list, but something that I think we do have to kind of acknowledge, and I have to acknowledge as a psychiatrist, is that 55% of psychiatrists, I believe, are not in network with insurance. And so it makes it quite challenging then for people who don't have significant amount of disposable income to actually access those services. It's very, very hard. So I think that many of these, and then the last thing I'll say is that folks really knowing what to do when there is a behavioral health crisis, because at this point in time, I think the only thing they know to do is to go to the emergency room. And yet we know that in so many cases, that's actually not going to solve the problem, and it's not going to link them to the resources that they need to actually get on the road to recovery.
I had a family member who every time she had some sort of anxiety attack, she would go to the emergency room, and it was not the right response, but that was the only thing she knew to do. And it was really frightening for her, but that was not the place for her to get the help that she needed.
Yeah, it's interesting, right? Because if I have chest pain, or someone I love has chest pain, then I know, hey, I'm going to call 911. And there's a very protocolized way in which my family member is going to be treated to make sure that there's a clear understanding of what is causing their chest pain and that they are safe. But if I call and my family member is suicidal, or I am suicidal, that goes out the window. There's not a clear protocol, and there's not a clear way that's going to be consistent, across. If I take 25 different ERs in North Carolina, there's not going to be a clear approach to that individual who's suicidal, despite the fact that in many age groups within our population, that is actually higher prevalence, greater threat than almost any other cause of death.
Chris, as we come to a close, any closing ideas you have for us, things that you think we could do that would make things better as we try to get through the rest of this pandemic, and more importantly, maybe go forward into the future?
Right. I'll share that, I feel in terms of our mental and behavioral health state of our country right now, this is a state of emergency, truly. Is where now more than ever, I think we're having more conversations about mental health and behavioral health, which I think is very good that we are including this as part of the public narrative, the public, conversation about livelihood in general, life in general. But that same conversation needs to be coupled with action from, both our public health agencies, our healthcare agencies, and our government leaders to invest in infrastructure to improve healthcare, improve behavioral health access for folks living in conditions like, rural communities, affluent communities, on campuses or elsewhere. Also including those conversations in earlier ages. I know one of the recommendations you previously showed was about starting conversations or including mental health in the curriculum of our public schools. And I think that would be such an important and such a beneficial step, because I never really thought much about or heard much about mental health until I actually got to college. And I know, looking back at my high school experiences, there were probably sometimes I was experiencing anxiety or depression or just confusion about things going on in my personal life, but that wasn't something we talked about in school. That wasn't something that was part of my upbringing in my adolescent years. So I think it would be very important, and it would behoove us to start incorporating those conversations about mental health, start increasing the access of mental health services to us at younger ages, and ensuring that those accesses are the same and equitable across the board. We need to incorporate it into our public health, diaphragm. This is something that is much a crisis, very much a crisis for many of us. And at the same time, I don't think our investment in healthcare, our investment in behavioral health has coupled or tried to match the increasing crisis that we're seeing in terms of the issues that are rising out of public health and behavioral health across this country and across our state of North Carolina.
Dr. Dennis, 30 seconds, closing thoughts on something we could do that would make things better.
I think that the number one thing that we could do at a systems level would be implementation of, and Blue Cross, we're trying to move towards this, of the collaborative care model in primary care settings, because that's a really high quality, systematic approach to trying to integrate behavioral health care and to have a sort of measurement based really logical approach to managing behavioral health concerns starting in a primary care setting.
All right. Dr. Nora Dennis, Chris Suggs, thank you both for being with us. Really, really appreciate your taking time. I know you're both busy. And Chris, good luck in the city council race. Best of luck to both of you. Finally today, if you have a loved one who is experiencing a mental health challenge, there are resources out there that can help. We want to make sure we lift up a sample of those. There are a lot of them. These are just a few that we think are important as you look for ways to go forward. And we'll leave these up for just a minute so you can look at them if you haven't seen them before. But these are places that you can go to reassure yourself that you are not alone. And there are resources out there that can help you. As Chris mentioned, sometimes it's hard to even know where those resources are. So these are some of them. There are others that are out there. So please, if you are experiencing a challenge or if you have a family member who is and you don't know where to go, reach out to someone who can help you. It could be another medical professional who may have advice. It could be a friend who's had some access, or it could be one of these resources. Please take advantage of these as you can. That is our show for today. First and Future Live is based on an idea from the Institute for Emerging Issues Communications Director Greg Hedgepath. It's produced every week by James Herrick. Social media and chat comes from Kirsten Chang. We had research help today from Shivani Mehta. If you like the show, please let your friends know about the recording that'll be available on our website, emergingissues.org. Our next show is coming up on November 9th. At the same time, 9 a.m. We do this every other week, and this is talking about food insecurity. For the past few months, the Institute for Emerging Issues has been working with students from 9 different universities across the state of North Carolina to develop their ideas on what we can do to reduce food insecurity in our state. We're going to talk at that time with Association of County Commissioners, Ronnie Smith, who wrote a statewide report last year on what counties can do to reduce food insecurity. Spoiler alert, if you're worried about the future of our country, I think you'll be reassured after listening to these student leaders, just as I was today, and hearing from Chris and what's going on in his life. I think you'll see next time that we are in good hands. That's it for today. My name's Leslie Boney. For all of us at the Institute for Emerging Issues at NC State, thanks for being with us. We'll see you in the future.